Good afternoon, everyone, and welcome to Emerging Issues in Harm Reduction, Family and Community Work, a three-part webinar series as part of a unique partnership offering continuing education opportunities to train social workers in the practice of harm reduction. My name is Jen Tracy, and I am the Chief Program Officer at the RIZE Massachusetts Foundation. RIZE is proud to be part of this groundbreaking partnership with the National Harm Reduction Coalition and the National Association of Social Workers Massachusetts chapter to expand knowledge and create space for dialogue about harm reduction and social work. We are so pleased to welcome you to the last webinar in a three-part series focused on family and community work in the practices of harm reduction. This series builds on our past webinars on themes such as cultural humility and harm reduction and the impact of stigma on substance use treatment. We are excited to have over 800 people registered for this series. As some of you may be joining us for the first time today, I'm happy to share some brief background about RIZE. Launched in 2017, we are the only public-private partnership solely dedicated to funding and creating solutions to end the overdose crisis. Our goal is to ensure that people experiencing substance use disorder have access to care and experience better quality of life and overall health. Guided by those with lived and living experience and unafraid of new ideas, RIZE is building networks, creating programming, and supporting community partners who are using novel approaches to preventing overdose. One of our strategies to end the overdose crisis is building inclusive networks to share lessons in exploring and enabling change. This is what we hope to accomplish during this series, as the crisis continues to take a devastating toll on families and communities. Strategic workforce investments like this ensure that professionals in the care continuum, like social workers, have the critical tools they need to directly support clients experiencing opioid use disorder. Harm reduction offers a set of practical strategies aimed at meeting people where they are at to reduce the negative consequences associated with drug use. Social workers are uniquely positioned to integrate those practices to improve client well-being. Once again, we're very proud to be partnering with the National Harm Reduction Coalition and the National Association of Social Workers Massachusetts chapter to bring the third webinar series to you. Before we get started, I just want to share a few housekeeping items. The webinar will run from 12 to 1:30. Participants will be muted throughout the full webinar, and please make sure you are muted yourself. But please feel free to add your questions and comments in the chat. We'll also reserve the last 10 or 15 minutes for a question and answering session. There will be a code provided to you at the end of this webinar that participants must enter into the course evaluation form to receive continuing education credit. You can access the link to the evaluation form from the email you received this morning. Thank you all in advance for taking the time to share your feedback. The slides from today's webinar will be shared with you after you complete the evaluation form. Please note that this webinar is being recorded and will be posted to the National Association of Social Work's online Community Education Institute, as well as RIZE's YouTube channel, where you will also find the recordings from our previous webinars. For this series, we will once again be led by our amazing partners, Tanagra Melgarejo Pulido from the National Harm Reduction Coalition, and Joe Pereira of Outlook Associates of New England. And with that, I will now turn it over to Joe and Tanagra. Thank you.
Thank you, Jen. Buenas tardes. Good afternoon, everyone. Good morning to some folks that are joining us from the West Coast. Am I speaking loud enough for folks? Can folks just let me know in the chat if, thank you. I am really excited to be here with you. And I'm a little sad because it's our last session and I've so enjoyed the ability to be in community with folks for this three sessions where we've been discussing and thinking more about harm reduction, and hopefully we can have more in the future. And I will do my best to enjoy the moment today. And I'm just gonna give my microphone. I'm gonna share my microphone with Joe so Joe can introduce himself.
Hello, all. I'm also very excited to be here for, and actually this particular topic, I think has been an ongoing interest of mine. And so just a quickly a couple of things. One of them is that even though I've worked in a lot of other settings, I'm currently in private practice. And I think maybe there are a number of you that are currently in private practice, and there may be some hesitation, perhaps, of working with people with substance use disorders. I'm hoping that we can provide a framework that will be more comfortable in helping you deal with potential risk in working with people in substance use disorder. The other thing I want to say is, I think I can speak for Tanagra, is that we've been really appreciative of people's participation, and we're hoping that in the we'll be asking a number of questions, and we're hoping that that will continue in terms of people participating through the chat with some of the questions that we're going to be asking.
Thank you. And Joe, I wanted to remind you if you can hold your mic closer to you when you're speaking. So yeah, let's just try that one time.
Testing 1, 2, 3.
Perfect. That sounds
Better?
amazing. Thank you. Much
Okay.
better. Thank you.
Okay.
And we're really excited also because we have someone joining us in a little bit who will be, I'm sure you will find him as amazing as we have found him and know him to be, that will be sharing direct experience doing this work. So we're really, really thrilled for the opportunity for you all to be in community with him as well. We will introduce him. So we'll keep him as a mystery guest until we get to the moment to share space with him. And so I am part of the National Harm Reduction Coalition. Many of you probably know who we are. For those of you that don't, we have been around for 30 years. Doing this work of building community and really working with people to create the spaces for dialogue and action that can help us heal the harms that are caused by racialized drug policies. We do that through a series of avenues. I am part of the training and technical assistance team. If you're interested, we have really amazing resources and publications that are housed in our website. I encourage you to visit it and check them out. If you're for some reason looking for something and you can't identify it or find it, you will have my email. Feel free to reach out to me. I'm happy to either find it for you or connect you to the person in our team that has access to that information. And so now I'm going to pass it to Joe to kick us off.
Thank you, Tanagra. And also, I just want to confirm that the website is a great resource for people, the National Harm Reduction Coalition website, and I really would encourage people to take a look at it. So to start off, and for those of you who've been in previous seminars, some of these questions are going to sound familiar, but I think in the context of the topic today, I think it's important. So if people in the chat could just, why do people use drugs?
To cope with life stressors, to self-medicate, to feel better, to numb, for pain management, to forget, to deal with anxiety, stress, etc., to solve a problem. For some folks, it's to escape, to numb ourselves. Sometimes it's related to dependency, for relief, as a distraction. For some folks, they use because they feel hopeless. Others use to avoid emotional pain or to deny. For some folks, it's peer pressure or the sense or need to be in community. Some folks use drugs to deal with trauma. For some other folks, it's around normalcy. It's what feels normal to me. For some folks, it's something that we do socially to enjoy ourselves, to party with others. Some folks use drugs because this is what we've seen growing up. I love this, Jennifer, to explore, right? To explore because we're curious. Human beings are curious, right? And that part of that curiosity and experimentation, as Alan is sharing. And Karen is sharing something really important. The pandemic was a big sort of, how do you say that in Spanish? Detonante, something that generated the need for folks to use drugs or to pick up substance use and again, because of the times that we're in and we're living in. Microdosing for some folks as a medical relief. Some folks use because they have anxiety or they are struggling with their self-esteem. Denise is sharing because some of us feel lonely, and using drugs can help us feel connection and community.
Right.
So they're all great.
Great. Thank you. Suicide,
Yeah.
medicine dependency, depression, hopelessness. Yes.
Yeah, I would add two things that I haven't seen that folks have shared. One of them is because they feel pleasurable, and because they work, because they work, they do exactly what they're meant to do, and what folks need them for.
Okay, and so the following question is, why don't people stop using drugs? So because they work, dependent on it, dependency because it serves a purpose, it's an easier option, a lot of the same reasons they use, correct? Fear, yes, fear of stopping and what that would mean. Comfort, don't know how, haven't developed more healthy, positive coping techniques. Again, fear, they don't know what helps them feel the same without the meds. Great. Answer, craving the drug. Brain chemistry, shame stops them for asking for help. And we'll be talking also about stigma and how that feeds into shame in recovery. It's not a problem for me. Trafficking victims, fear of loss, denial, unhealthy dependence. It's difficult. Yes. Pleasure pathways. So, yeah. Environment, being surrounded by others who encourage it. Correct. Fear, again, another one there.
Okay.
Great. Okay.
So I think one of the things that we already read that folks wrote is that the reasons for using and the reasons for us not stopping are very much the same, right? We know that people will have different reasons for using drugs. There is 167 of us in this room, and I bet you there is 167, if not more, reasons why we would use substances, right? And I think the important piece, and I think the piece that harm reduction allows us and gives us room for, is to create a space free of stigma, right? Where we can think with folks, brainstorm with folks about options that they have, you know, that they may be already putting in place, that they may be already engaging in, or to think about new potential options to reduce risk for diseases or for fatal episodes, right? And the important piece also is that harm reductions gives us room to consider the factors that are surrounding those behaviors. It gives us room to go deeper, to explore further, to really think in partnership with folks about their substance use, to acknowledge that there's benefits that come from that use, that that person recognizes and sees, and also to explore and consider what could be the potential harms or dangers, right, that they can see in terms of their use. And harm reduction is a philosophy, is a practice, is a framework, is a movement, right? And there are 4 core tenets that are part of this harm reduction practice, right? Participants need to be involved. The person needs to see themselves as an integral or integral. Integral, I always ask this question. I can't remember how to pronounce it. I always pronounce it with my Spanish accent. They're a key element of the equation. Without participant involvement, we are wasting our time and the participants' time. So participant involvement, meaning I see this person as a subject matter expert in their life. I see this person as someone who deserves my time, my energy, that deserves the room to explore and think about their health and their well-being and what it means for them. Any positive change as defined by the client and participant. We may be thinking of positive change differently than the person. In this instance, when we're thinking of harm reduction, we're looking at creating space for folks to identify that positive change, and we want to validate that positive change, right, as identified by the person. That means we are willing and open and mindful of respecting people's autonomy, giving room and creating room for people to make choices, to make decisions, to explore how to do that, to work with people sometimes in helping them navigate and to gain the skills that they may need to be able to move forward from a place of autonomy, of self-determination. And finally, unconditional positive regard. And because it's last is not less important, we have to see this person in front of us as a human being that deserves to be loved, a human being that deserves to be cared for, a human being that deserves to move through the world feeling safe and cared for. Many times participants, folks who use drugs are so dehumanized and so invisibilized that the way they approach us and come to receive services from us, they're already really guarded because they have been treated really poorly. And I think this piece of unconditional positive regard is really, really important because it allows us not only to see this person in front of us as a human, but to build bridges, to create that rapport, to strengthen that rapport with that person, and to really open ourselves as practitioners to learn from the person in front of us.
Ginevra,
Yes,
can I
Joe.
say one thing
Claro.
about the positive change? What, for people to consider recovery, people in recovery, that is often associated with abstinence. And, what I would ask people to do is to consider that to have recovery be a much broader sort of way of thinking about it. And in terms of health, in terms of well-being, in terms of their relationships with other people. So I just wanted to make a comment about that.
Thank you, Joe. And I think I can look for these and share them with Chris Belli to share them with folks. I don't know if folks are familiar with SAMHSA's principles of recovery. They very much speak of recovery exactly as Joe is saying. And they also uplift harm reduction as a piece of the recovery continuum, right, as well in that sort of spectrum. So I will make a note to myself to share that information with folks. If you're interested, you can access it and check it out. The other piece that is really important, and again, it's so important that we're naming it twice, maybe more times in this session, is this concept of personal autonomy. And we have borrowed this definition from our colleagues at NASTED, and we liked it so much that we asked for permission to use it. And the way that they're defining autonomy and the way that Joe and I would like to sort of invite you to think about this with us today, and hopefully moving forward, is consider autonomy as a person's capacity for self-determination and self-governance. I would say an individual's right for self-determination and self-governance, right? Acknowledging that when we're working with folks who use drugs, it requires us as practitioners, as providers, as clinicians, to respect the choices of the people with whom we're working, right? It may not be the choice that Tanagra Maria Melgarejo Pulido, when I was in trouble, my mom would call me by my first, my second name, and my two last names. And I knew it was like, oh, this is no bueno, right? That I would make. But it is essential, right, that we respect that choice of that person as their right. And it also invites us and reminds us that we should recognize that most often than not, folks that we're working with are making the best choices they can with the tools and resources they have. And I think folks mentioned earlier why people don't stop using drugs. And we mentioned lack of resources. We don't know how, right? Many times, I don't know what I don't know, right? The thing that I know that works is using substances. That helps me address my anxiety, my fear, maybe my mental health issues, maybe allows me to connect to myself to feel pleasure and joy, or gives me room and permission to disconnect from the world when it gets really, really heavy. I know that works. I may not be aware of other things that may work for me, or I haven't felt invited to explore those. And so thinking about personal autonomy as a space where we can begin to have those conversations with people as well, and explore that from a place of the person gets to make the choice that they think is best for them in this moment. And we can also, through rapport, to relationship building, continue to have conversations to learn from them, and hopefully share consensually and with permission other options that they may be interested in exploring further, now that they feel safe doing so with us, in community with us, in relationship with us. And then another concept that it's really, really important for harm reduction, and we're borrowing this from Pat Denning and Jeannie Little, and you are going to, in a little while, see a short video where they are both speaking, who are the co-founders of the Harm Reduction Therapy Center. And they are the OGs. They're the first therapists that began working in therapy or framing their therapeutic approach from a harm reduction lens. They've done so much work around this area. They have produced like materials that are incredible for folks that are in this field. I encourage you, we'll share with you some links. They have several books. One of them is Over the Influence, that have been seminal, so important for our movement and for the movement of therapists that are looking to work therapy from a harm reduction lens. But they came up with this concept of radical neutrality and acceptance. And what they are telling us, that if we are providing harm reduction services from a therapeutic lens, we as providers, as clinicians, as practitioners, have to be willing to engage in this practice, which means that we will be grappling with ethical gray areas. It will happen. It's not avoidable. It's how we grapple with those ethical gray areas, how we do that to minimize harm and risk for the person. And we need to think about what that means, right? We need to tolerate, accept, and understand behaviors that may be difficult, that may be challenging, that may be new, that may be different, that may be foreign to us. So approaching this from a place of curiosity instead of judgment. We have to be open to be taught by our clients, right? Which means we're relinquishing the role of judge, authority, or expert, because ultimately what we want is to be able to build a partnership with our clients. We want to work with them. We want to create a space where they feel supported, heard, and listen, and a space where they trust us to share our expertise with them, what we bring with them, and to trust them that they will take what works best for them in this particular moment. So I think this piece of radical neutrality and acceptance and this piece of personal autonomy will be really important for us to keep that in mind as we're moving through this time that we're together, and particularly when Maurice, who is our guest speaker, comes on and shares his experience doing this work, to think about, you know, how radical neutrality and acceptance are two key tools that we have to help us engage in a practice that is more rooted and centered in the person, rooted in humanity and not in stigma and shame.
So, Tanagra, can you go back
See?
again? One other comment. Thank you. So thinking of this kind of with a clinical lens, being aware of using that term of our countertransference, of our feelings towards people who use substances, and being honest with ourselves, what may get in the way of being radically neutral, and being able to sort of own it. I remember a number of years ago, a colleague of mine whose husband had an alcohol use dependence and was quite challenging to live with. And she was very open about, at this point, I cannot work with somebody with a substance use disorder. It is too personal for me. And at the very least, appreciating her honesty about that. So I think that that's really important to keep in mind. And also, as Tanagra, in a couple of minutes, we'll talk about stigma, what we have internalized, the messages that we have internalized about people who have used drugs, and we can't get away from that. So in thinking about the substance use spectrum, I think this is a really good way of looking at, so when we think about risk, that obviously as we go along this spectrum, there may be more challenges with risk. Clearly, non-use will be the least amount in terms of risk, obviously, because the person is not using a substance. But what I guess a couple of points I would just like to make, that, and I would say under beneficial use, I would put experimentation under that, just kind of testing the waters, that sort of thing. And then the second point I would make is that there are examples of use that I think fall between lower and higher risk use. So, for example, adolescents obviously like to experiment, and you know, they want to kind of test it out. However, as we likely know, the earlier a person starts to use, the more impact that's going to have on one's sort of brain functioning and brain's development. So there's a risk factor there, even though, for example, they may not be heavily using. And then the other one that I see sort of as an example between lower risk and higher risk is people who go to college and engage in sort of binge drinking and not knowing the full consequences of that. And every year there are people, again, a lot of times in college, who die because of an alcohol overdose. And so I think that probably falls in that lower, higher risk use. The other thing that I would say is um, how drugs, even those people who might sort of fall under the addiction category, in some ways, they may be able to manage risk better because they know the consequences and they've been around it and that sort of thing. So don't necessarily, again, automatically assume that somebody with a higher that somebody may have an addiction issue is at higher risk. And then the last thing I would say is, again, and this goes back to perhaps radical neutrality, is being aware of, again, of our own prejudice, that if we think, okay, somebody is IVing a drug, that puts them immediately at high risk. That isn't the case, and you have to kind of assess the particular issues that are going on for that individual, which we'll touch upon in a few minutes.
Thank you, Joe. And I would just say also that in the United States, there's RTI and other folks have been carrying out a longitudinal study around substance use with NIDA and other folks. And the reality is that in the United States, the folks that fall on the addiction or substance use disorder category is very small, the percentage considered, if we look at the whole of the population, right? So that's one thing. And then the other piece is that I think that we need to be aware of the other intersections that put people at risk: racism, misogyny, trans and homophobia, capitalism, right? Economic violence, state violence, all of those things are also issues, realities that put people at further risk, right? And that interact with that person's experience of substance use, that we should keep in the forefront of our mind as we're thinking with folks in terms of where do they see themselves in this spectrum.
So very quickly, if again, this is a question for the audience, pretty straightforward. What are some harms that can come from using drugs, maybe on your own experience or in your experience in working with others? Family breakdown, health risks, loss, health problems, family problems, death, of course, yeah. Memory deficits, increase in health issues, financial problems, dependency, job problems, homelessness. Sense of reality changes, yes. Loss of autonomy, separation of parents from their children, isolation, incarceration, legal problems, unemployment, loss, health, death, again, lose custody, financial difficulty, isolating, yeah. All right, well, thank you. Hopelessness, relationship issues, yes, thank you.
So now we want to ask folks this next question, which is, how can stigma magnify the harms that can come from using drugs? So we mentioned
I am
many
aware
harms.
of these things. You have a worry monster. That.
Oh, and what we want to hear is how can stigma magnify these harms? Yes, Debbie, yes, we will provide the slides as soon as you're completed the evaluation that you will have access to. You will have access to the slides as well. So this will make this available to folks. Yes. So how can stigma magnify the harms that can come from using drugs? Let's see. We see here Jen is sharing, by keeping someone from being honest about problematic use, can increase feelings of hopelessness. It creates isolation. Stigma magnifies denial of problems and help-seeking behavior. Stigma can interfere with ability to get or ask for help, acknowledge that we have an issue, stop people from trying to stop, this sense of hopelessness, preventing access to resources, less likely to seek help. There's shame, yes, preventing them from accessing treatment. There's guilt also, self-loathing, can impact self-esteem, it taking someone from not seeking support, afraid to admit how much we're using, labeling of a person, increasing self-esteem and contribute to isolation, hopelessness, denial, fear of judgment from family and friends or children, a sense of failure, absolutely. Prevents people from seeking help when they're ready or when they feel that that's the moment to do so. So we know, and we know this because there's been many studies that have been carried out around the impact of stigma and in the lives of people who use drugs. And we know that it's the most insidious and prevalent harms that people who use drugs experience. We know that stigma literally kills people, right? And so now I want to share a brief video with folks that speaks to stigma, and stigma particularly around substance use and stigma experienced by people who use drugs. I would love to hear some of your feedback in the chat once we have finished watching it.
Stigma is the mark of shame and embarrassment connected to a personal trait, quality, or behavior, like drug use. We create stigma when we hold and promote negative views about people because of who they are, what they do, or their circumstances in life. Stigma can become structural, meaning it affects the way entire institutions or organizations treat people. When hospital workers ignore people who use drugs and fail to take their health concerns seriously, that's an example of structural stigma. Many people who use drugs experience stigma every day. Because consuming drugs like heroin and cocaine are illegal, people who use them are frequently criminalized. And this leads to being stigmatized twice. Once as a person who uses drugs, and a second time as a criminal. Stigma creates real barriers for people trying to access healthcare and vital social services. Because of the shame that stigma causes, people who use drugs often avoid asking for needed help or telling anyone about their substance use. This creates a harmful cycle where those who would benefit from help the most can't access it. And this further marginalizes them in society and compounds harms related to their drug use. People who feel ashamed are also more likely to use drugs alone. This means they are at greater risk of dying because no one can revive them with naloxone if they overdose. We can all work to eliminate stigma by how we act, using non-stigmatizing language, for example, or by being more inclusive and understanding of those who use drugs. Stigma is not just felt, it has real-world consequences for people's health and safety.
The short video. I would love if folks have any thoughts, any comments, anything that kind of resonated with you as you were watching the video. You can.
Tanaga,
Yes, Joe.
as people may participate, one of the things, for those of you who may have attended our previous workshops, I think every time we talk about stigma, because it is such an obstacle for people to engage in treatment, both personally, structurally, and so we feel like it is important to kind of reinforce. A British writer said that oftentimes we need to be reminded more than we need to be instructed. So I think it's in that context that we're talking about this.
Thank you, Joe. I see Julia sharing in the chat. Reminds me of a medical director who referred to folks who have become addicted or dependent to prescribe medication as bad actors. That word "bad" rare, like right there, just qualifying. It's like a sticker you can really rip it off. Victoria sharing structural stigma also can look like people struggling with use or addiction are assumed to be untruthful and untrustworthy. Absolutely. Or they don't care about their health. They're not interested. They're lazy, right? They're just, you know, why bother with them? They're not going to follow through, right? Like that's how we start thinking. There's Alexia loved the suggestion of the use of inclusive language, which is such a small lift for so many of us to be mindful of our language And yet it makes such a difference, right? When we think about the language that we use and how can it can open, right, and constructs a reality, right? Language is powerful. It helps shape the way that we view the world and we see each other. So that piece of inclusive language is something that it seems small, and then it's huge in terms of relationship building and really shifting the paradigm around people who use drugs. Eric is sharing, have seen this in medical settings, how patients who are coping with SUD are treated, right? People are pushed aside, pushed away. I've talked about being aware of the language we use. Could you expand on that? We actually shared, I think in one of the previous sessions, a small glossary around specific terminology that it's best practice to use. Also engaging in person first language, thinking of the person first and then their behavior second. Many times we think of addicts, junkies, we use this terminology and we fail to see that this is a human being in front of us. So thinking of a person who uses drugs, person living with HIV, person navigating substance use issues, right? It kind of centers and uplifts the human first. And I think, Joe, we can also share with Chris Belli some of the person first and inclusive language resources that we have that are great.
Absolutely, yeah.
Yes, Joe.
Just a comment here, I think it's worth saying. Very true. People are very judgmental, evidenced by a recent conversation where someone told me junkies don't have anything to contribute. They're better off dead. That hurt my heart to hear this. So yeah.
And we're talking also, Jen is sharing about, beyond stigma, our systems are just, just failing people left and right and failing us and failing participants. Thinking about the fact that we don't have trauma-informed or drug-informed healthcare, right? We don't have very good drug education, if any at all. And so that lack of understanding also prevents people from seeking help because you get judgment and not an understanding of what would be the reason why this person may be using this substance. And then, right, Ruth is sharing adding racism and top of stigma, etc. Jolian is sharing that even in a hospital waiting room, Jolian is in Puerto Rico. I'm in Puerto Rico too, Jolian. So, hi. You can hear the comments that are stigmatizing from the patients or staff towards the people who are coming in to receive services, people with visually or obvious substance use or what they perceive as homeless. De Aguadilla. Well, you're on the other side of the island. So it's nice to have a Puerto Rican colleague here. Welcome.
The other thing I would say too is again, and I think people made reference to this, for those who are using substances, the stigma that they internalize as well as being bad, worthless, and how that interrupts or interferes with their getting help. So for the sake of time, here's a question that we're going to just pose in general for you to think about, but we're not going to ask people to do the chat room. But some of the challenges, obviously stigma, poor understanding of the effects of different drugs and why folks would choose to use them. And then being a mandated reporter around issues regarding substance use in the client's family, which I think is a real challenge sometimes for individuals. And then also fear of of a person hurting themselves or others as a result of their substance use. So just kind of briefly want to touch upon, and again, I think this is a great model to use as you're thinking about the individuals that you're working with. This was developed by actually a local psychiatrist at Cambridge Health Alliance, Dr. Norman Zinberg, who was studying people who were returning from the Vietnam War, veterans who were heavily involved in substance use while they were in Vietnam. But many of them, when they came back, they stopped using. And so he was curious about that. Obviously, there were people that continued on a trajectory of maybe dependence use, but many of them just stopped. And so he developed this notion of drug, set, and setting, and that each of these dimensions is going to impact on the effects and ultimate risk that people may experience. So obviously the drug and how it's used, how much is being used. So in terms of how a person is using it, whether they're snorting it versus smoking it versus an oral intake of it. And so the psychopharmacology of the drug, let's say alcohol versus marijuana, different kind of risks in each of those substances. The set refers to the individual person. And so if an individual who has co-occurring disorders, they may use more to self-medicate. And so that might increase their risk. And then the setting. So the environment, the physical and social environment. So kind of what Sanagra made reference to, the impact of poverty and discrimination, seeing drug use as an escape. And then also, I think this was also mentioned in the chat at one point, also people that they may be spending time with. I'm working with a client yesterday who I saw whose daughter was in a motorcycle accident. She was on the back of a motorcycle, not using a helmet, and she fell off of it. She was injured, but fortunately, it wasn't really severe. But she was in an environment where there were a lot of heavy drinkers, and so nobody was there saying, "Hey," and she herself was under the influence, but there was nobody there to say, "Hey, maybe not a good idea." Um, to be driving on the back without a helmet, and the person that was driving the motorcycle was also likely under the influence. So that also involves the setting.
And so now we are going to show you this short video of Pat and Jeannie speaking about harm reduction in their practice as it's a way to then introduce our guest speaker. So let's hit this.
That we need to become comfortable with drugs and with drug use. In order to work with people who misuse drugs, we also need to understand why drugs might be chosen as a solution to other problems that people consider to be much more important than their problems with drugs, assuming they have developed problems with drugs. As Pat was saying earlier, people have, she thinks of people coming into harm reduction therapy as coming into couples therapy. That we are working with a person who has a relationship, and that relationship is with drugs. And for us to fully embrace that person, we also need to embrace their relationship. And for that, we need to accept that it's a legitimate relationship, and we need to accept the thing that they're having a relationship with, which is drugs. So I think it helps to think of drugs as medicine. Medicine for pain in our bodies, medicine for emotional pain, and medicine for what some people might call the soul, which doesn't mean that the soul is injured. It just means that for some people, drugs are used to enhance experience and enhance perception, and that's super important. It's important or helpful to remember that drugs come from plants, or they are modeled on the psychoactive or medicinal aspects of plants. And it helps to know or to believe that humans have co-evolved with psychoactive drugs for millennia. Cultures all over the world have used psychoactive plants in cultural and religious ritual. They help us to see the world, ourselves, and each other differently. In the context of a social or religious ritual, intoxication is not scary. It's just different. It's a different kind of experience than we have when we are not intoxicated on drugs. There are rules and customs in ritual that create community and that create safety. Not everyone enjoys or seeks these mind-altering experiences, but many people do. And when we work with people who use drugs, it will help us if we can accept this. Understanding drug use as a normal human process is the foundation of being genuinely accepting and genuinely non-judgmental of people who use drugs. Understanding that people who persistently misuse drugs are likely trying to manage some kind of trauma, physical pain, or mental and emotional distress will help us to accept and to understand each individual we meet. And it will help us to do a compassionate assessment of the underlying distress or pain. It will help us to develop a relationship with each person based on what they need, and that will help them to trust us. Do you want to add anything to?
Well, yeah, I want to
Mhm.
expand on something you said at the very beginning,
Mhm.
that we need to be comfortable
Mhm.
with people's drug use, um, and that is much more difficult than you might think, or it's much more difficult for some people than you might think, and partly that comes from negative attitudes in our culture. Some of it comes from negative experiences within our families or communities, and some of it comes from just a lack of knowledge. It's really important, if we're going to work with people who use drugs, that we know what drugs are, that we know the difference between methamphetamine and heroin, that we know the difference between cannabis and alcohol, that we have some, at least intellectual, if not personal, knowledge of drugs in order to bring a new and different perspective to what our clients' experience is, so that we could begin to have a mutual understanding of it.
Well, I hope that this has piqued your curiosity as we move to introduce our guest, who's Maurice Bird. Maurice is Director of Training and Business Operations at the Harm Reduction Therapy Center, which is based out of San Francisco. And we hope to have a conversation with Maurice around harm reduction therapy in practice, both gifts and challenges. I will briefly, you'll have this slides and you'll have Maurice's bio. I just want to say that Maurice has been doing this work for the past 20 years. He is an accomplished harm reductionist. He is a practitioner. He walks the walk and talks the talk. He is an amazing, kind, compassionate, very skilled practitioner and human being. And it's an honor for me, and I speak for Joe, to have him joining all of us today to continue to dive deeper into this idea of how do we approach our therapeutic practice from a harm reduction lens. I will stop sharing my screen so you can see Maurice's lovely face. So I'm going to stop sharing my screen, and that way we can spotlight Maurice, who's there. Hi, Maurice.
Hello.
Thank you for joining us from the Bay Area this morning.
How are you?
I'm really excited. I'm doing well. I feel really honored I mentioned this to you earlier, when we met initially, to share this space with you. I am actually really selfishly very excited also, because I know that I will be learning from you things that I can bring to my practice, and also a lens through which I can also look at my practice as well. So I am just really excited for the banquet, as we would say in Spanish, el banquete, that it's this conversation with you today.
Yes,
I'm
and
excited.
just a ditto for me. So great, Maurice. Thank you for joining us.
So I will start us by asking you if you can tell us about yourself and how you came to use harm reduction as the framework that you apply and that you view your therapeutic practice.
Yeah, I'll say, again, thank you for the wonderful introduction. That's a lot of pressure. I'll do my best to live up to it. So yeah, I'm Maurice Bird, he and him pronouns. I'm joining you here from a lonely land. I happen to be at home in Oakland. I'm driving to San Francisco after this. A little bit about myself is, I'm a person I was born and raised in San Francisco, California, and grew up in the neighborhoods where there was a lot of drugs and drug use. And for me, you know, it affected me personally, it affected my family, affected friends. I definitely have family members and friends and myself too that have been severely affected by the war on drugs or the failed war on drugs. And I think that's when my passion first started, like for harm reduction and what that meant. And I think we were practicing it before I had a word for it. Me and my family and people around me were sort of practicing that. And my journey to harm reduction was, interesting in the sense that I ran into Pat and Jeannie, who we just showed a video. At first, I found their book. I found their book, and then maybe a month later, something like that, I actually ran into the two of them, and they were my clinical supervisors when I worked for a different organization. And soon I started working for a harm reduction therapy center. So my formation of what harm reduction using the word, was over 20 years ago with Pat and Jeannie, and really understanding what harm reduction was. So I've been very fortunate that I was trained by, the two folks that y'all just showed, and they were my bosses and my teachers for the past 20 years, still are. They've retired, and me and three other folks have taken charge of running HRTC now. And I think the framework, to me, the harm reduction therapy framework, the big harm reduction, the big H too, is based around common sense. It really is to me. If you can center, social justice and human rights and public health and housing and all, if you can centralize those things, and something else that's important to centralize, that you love people. It's okay to love people as well too. I think it just starts making sense to you. The last thing I'll share, because I think it's important for us as folks who are providers in roles that we're in, I like to share with people, I'm a person who uses drugs too. And I love people who use drugs, and that has sustained me in this work.
Yeah, I think something that I found really enlightening when I first heard Pat and Jeannie say this is, in order to do this work, we have to acknowledge that we're working with someone who has a relationship, right? And recognize that relationship as valid. And I think that really centers the person's experience, which is individual, right? It's my individual relationship to substance use, right? And how that shows up in my life, the tensions, right, that I may have around substance use too. As you mentioned, for some of us, we use substances, and we also know that the failed war on drugs has impacted Black and Brown and Indigenous communities significantly. And it's being used as a tool, right? Drugs have been used as a tool to punish, to harm, to hurt people. And we don't talk necessarily and provide good drug education as well, which I think something that the Harm Reduction Therapy Center does, right? It's like, how do we talk as therapists about substance use with people if we don't know what we're talking about? Right. Yeah. And that makes it really uncomfortable. So I wanted to ask you, do you think that your understanding or your relationship to substances and that knowledge has helped you to create spaces that feel safer and more and más honesto, or more honest when you're working with your clients?
Yeah, I'm going to answer that question sort of directly and not, if you don't mind for a moment.
Of course.
Sometimes folks that are in social work or therapy, it may be intimidating to work with somebody who uses drugs, because we don't know all the things about drugs. I think it's paramount, if you're gonna to sort of double down on what Jeannie and Pat were saying, it's paramount that you have some working knowledge of drugs and drug use. That word that you were talking about earlier, Joseph, is that we can manage our countertransference as well too, which means this is integral, I think, integral to harm reduction therapy, or just working with people who use drugs, period, or working with people who have a lot of difficulties in their life. There's a lot of supervision. I don't think that's often promoted enough. So I think if you're comfortable enough after you start working with people who use drugs that are, and that's sort of the central tenet of part of themselves that they're working on in therapy, because I'm here to tell you, most if not all of us use drugs, and when I say drugs, I mean the big D. Whenever we say drugs, we're often talking about like the illicit drugs, but most of us you know, I do this in trainings all the time. I ask people how many people use drugs, and then a few people bring their hands, and I say how many people drink coffee, and then everybody's hands up, right? Is because there's some level of drug use that people are all in, and I think just understanding that, right, that Carl Rogers notion that y'all had in there earlier about unconditional positive regard, if we can really lean into that, because sometimes, again, it's intimidation about working with people who use drugs is the stigma that's sort of related to it, and then our own internalizing stigma as well too, because we all have it. I have it. I've been working on how to not have it for 20 years. It's still something that happens for all of us. Media, the society, culture feeds that to us. But I think kind of having that baseline, that footing of like, what are the basics about drugs, and which of those basics are misinformation or disinformation, and when is it accurate? I've worked with a lot of clinicians who are like, I can't work with this. We get a lot of referrals at the Harm Reduction Therapy Center from organizations in the center, and we all, the central reason why we get those is because they say we don't know how to work with people who use drugs. And if you listen to Pat's story, when she talks about how she because Pat was like sort of the real creator, if you will, of harm reduction therapy in practice. She was doing it in San Francisco in the middle of the AIDS crisis, and really in '85. I asked her, how did you learn how to work with people who use drugs? And she said, I just made it up. And I said, what do you mean? She said, I used all the same tenets and things that I learned or trained to do with people who have mental health issues. I did the same thing with people who use drugs. And if you ask people what they need, they'll tell you what they need. And then she went with Alan Marlette and all the rest of those folks and start really sort of diving in, creating a theory around it. But part of what I say to folks is that you kind of just rip the Band-Aid off. I think there's an issue that somebody asked a question earlier about liability and about being able when you're mandate reporting and all the rest of those things. But there's not a lot of risk around it. And I know there's sort of a question around that as well too. I think just getting more comfortable, flexing that muscle, building that muscle up with people. How can you actually really commit to someone being the expert of their own lives? How can you actually commit to you not being so tethered to a goal that you have for a person versus what they actually want and what they need? And then when can you, this is the tricky part, right? And this takes a little time to work on. When can you at the same time, one, offer your expert opinion, which is, I think this may work for you, and also honor whatever their goal is as well too. It's a balance. And if we apply, by the way, I think we apply these things to every other condition besides a substance use disorder. I always tell people, you're kind of always working in harm reduction whenever you're doing therapy with people. Let's say somebody has depression. You're working on a harm reduction plan with them. You don't tell them stop having depression and then I'll work with you. No, you're kind of doing a moderation with them towards a goal, which we call more progressivism. Can we apply those same principles and skills and training to people who use drugs as well too?
Thank you, Maurice. There's a question, Joe, in the chat from Jan that I think it's kind of it's going in the same direction you were going, Maurice. I'm gonna read it. So Jen is sharing, I do get a lot of new therapists who tell me they are afraid of working with folks with substance use disorders because they are afraid they will die from drug use, and they feel overwhelmed by that prospect. Can you address that risk at some point?
Let's hold this tension together. This is a tension to hold. Is that it is possible for anybody to overdose on a drug, period. That's the human condition. Are some people more at risk? Yeah. Will let's say the person has a trajectory and we can somehow predict in the future that they're going to die. Is that person going to die whether they meet with you or they don't? In this scenario that we've just created, yes. Is it better for them to have some time with somebody who loves and cares for them and all the rest of those things and offers unconditional positive regard and love and all the rest of things in that process? Now, there's no liability risk with this. By the way, you're not liable for anyone's drug use unless they're sitting in your office with you and shooting up with you.
Mhm.
That's different. That's a different risk, and I hope nobody allows that boundary to be crossed. That is a firm boundary that we should not be doing. And it's not true that the ultimate result of drug use ends up in death. That's just not true. Um, Joseph, you were talking earlier about like people who drink too much in college. The ultimate result is not always death.
Right.
People who use
Right.
cocaine or any other drug, the ultimate result is not death. The majority of people who use drug, the ultimate result is not death. Even though it's a huge number, the percentage of people who actually overdose and die, I want to honor the huge number and also keep this tension is that it's a small percentage of the population actually. Whenever you actually start doing the numbers on how many people run into problems, you're referring to this as addiction. I refer to it as physiological or psychological dependence on a drug. It's around 12% of people in use drugs on a regular basis. So it's fairly small. I'm moving away from the question and not let me come back to it. Is I think one of the things that why people don't work more in a harm reduction way with people because it's not black and white. It's not so black and white whether we want to think about this continuum of drug use like y'all shared out earlier. Like not all drug use is abuse, not all abuse is dependence. So it makes it more difficult whenever you're not working with somebody with the goal of being abstinent. I want to say this that abstinence is absolutely a part of harm reduction, but it's not the only goal. We offer people a menu of options. I think it's a little more difficult because there's a part of this that has to do a little bit more work. We have to, meaning we got to work on our counter transference. We have to be able to hang in there with somebody whenever they're doing things that I think are risky. We also have to be able to hold the tension of like, wow, somebody's using a really dangerous drug. And if I prioritize people being safe as possible, healthy as possible, and alive, that's what's important. Now, I think people fare better when they're actively using. They're in the middle of their use, maybe not high, but they're in the middle of their use, their journey in use, and they have somebody to talk to about it. Harm reduction therapy really is about helping people work on their ambivalence about their relationship with substances, prioritizing safety first. I say this often is when somebody comes into my office and they say, Maurice, I'm using heroin with needles and I'm doing sex work. One of my first responses after saying hello and all the niceties is to say, do you know where your closest needle exchange is? Do you know where to get safer sex supplies? Because I want them to be healthy as possible, safe as possible, and alive. If you can just focus on those three things, that can sort of enter you into a relationship with someone. And you want to be able to have a relationship with someone that is long term if needed. So your door is always open. Now, that same person comes to me and I say, well, stop using heroin and don't do sex work anymore. I don't know how that goes, in the first time that I meet them. I don't know them. They don't know me, for me to go that way. So I think it's important to hold that tension, and have people die that we work with before. Absolutely. Absolutely. Which is a hard part. And whenever that happens, I know this is not always the best way of somebody feeling about this or talking about this is I truly believe that wow, at least they had some time with someone that show them dignity and respect and we're looking out for them and maybe even show them love along their journey.
Yeah. Thank
Can
you,
I,
Maurice. Yes, go for it,
yes,
Joe.
great
Oh, the
question,
microphone.
Maurice. Oh, sorry. Uh, and maybe this is, so I'm going to take the liberty of being a co-presenter and asking this question, but I think it came up. Sort of and I think a lot of people who are attending, this notion of working with somebody who may, let's say, have children in the home.
Yeah.
And so the kind of the balance between, again, being a mandated reporter, the issues of safety for those children, but also wanting to try to have a dialogue and an openness with that individual. I'm curious what your thoughts
Yeah.
are about that.
Yeah. I mean, and I'll just talk for the California standards of being mandating reporting. Is that drug use does not necessitate that you do a mandated report. It doesn't. I want us to also wrap our, hold this in our mind when we're thinking about when it's time to call or make a report, is race, class, power, and privilege, and how that plays out. And I'll say that because I work in community health mostly. I also have a private practice, and I've worked with, rich white women who drink a whole bunch and go off sometimes, and the police come, and their children haven't been taken away from them. And I've worked with poor Black women who are not of means, and cannabis came up in their system, and their kids were taken away from them. Now, we need to keep that in mind. We need to actually stick to the standards of what a mandated reporting is. It's neglect and abuse typically, right? It's some form of neglect and abuse that's going on. That's the standard that we need to be working with. I am sure there are plenty of us had parents that use drugs, whether that was alcohol or weed or something. Plenty of us may be parents, and we also may use drugs as well. To think about that, I always want to close that gap really quickly between folks being like they use drugs and I'm the provider. We're all having this human experience together. Most of us use some drug. What depends. Potency may be different. So we need to base it on what the reporting asks us to do. Now, there's reporting that comes from like our license, whoever licenses our state licensing, and then there's models that we use, like APA, for example, who would suggest that you don't work with somebody who uses drugs. Those are not that's not our standard. Some people may have a license, but that's not our standard. We stick to our standard. If there's abuse that's going on, neglect going on, our role is to protect children. That's our ultimate role. That's mandated reporting duty. Our elderly folks, or people with disabilities. Beyond that, drug use does not necessitate a report.
Yeah. I think that is you're asking us, and I appreciate that you're asking us to really think about the role that our own prejudice and our own internalized stigma plays in terms of what we view as or consider neglect or understand as neglect, right? Or behaviors that could perceive as neglect. I remember I was working here in Puerto Rico with a person who was a survivor of intimate partner violence, and she had small children. And I remember that she came to our office. We were offering her housing and other services, and she came in crying because the social worker at the school where she was taking her kids had admonished her and shamed her because what she had given her kids for breakfast was a Coke and an empanadilla, right? And she was like, you are killing your kids, and she was saying, I'm feeding them, right? And first of all, that's what she had eaten growing up. So for her, it was a sense of like, this is comfort for me. B, it was affordable because it was cheaper to purchase that on the go, because she also had to walk with the kids like 1.5 miles to get to school. And so thinking about this social workers in her head, her notion of like, kids should not be eating that's sugar and fat, right? She's not nourishing her kids. She's been abusive. She's been neglectful. And she was really horrified. She was really, really scared. This woman was put in a really vulnerable position because this person who had power, as you were saying, and positionality, had threatened her basically with starting a process because of that judgment. And that to me is really harmful and really, really dangerous. There's more harm to be done in situations like that, right? Instead of ourselves asking, is substance use something that is putting in reality and truthfully, right, people in harm's way or not, right? And how do I understand that?
And again, it's not about the substance use itself. It's about somebody is putting a child in with direct harm in some way. That's our standard. I don't care what I don't care if they're using drugs or not.
Exacto.
That's the standard we need to use. But I think sometimes we jump to a conclusion easier whenever it's a person who uses drugs, whenever it's a person of color, whenever it's a woman. You know, it's easier sometimes to jump to those conclusions. So let's use our discretion. You know, there's a level of discretion that we have because it's about that the woman you just talked about. It's about her experience in the world, right? And then it's
Mhm.
about the perception. And then we got to remember as mandated reporters when we start a process, what does that mean for somebody? We may have just changed their life completely unless we've done a full-on assessment. You know, I'm not going to immediately jump on the phone or write a report unless I know that something is really going. I need to be doing a full-on assessment.
Mm-hmm. Absolutely. And better understanding too around, that person's reality, as you're saying, before we even jump to do something like that because of the potential harms.
Well,
Mhm.
and Tanagra, I think your example of this person, it also is going to keep them away from treatment
Yeah.
because they're going to feel like this other person is going to take their children away or shame and judge them, and so it just has the opposite effect. There is an interesting question here from Tara. Um, so sort of a random question. I know typically in the substance use treatment, oftentimes it is encouraged that one work with others who have a history of substance use disorder, whether it be mentoring, running treatment, substance use disorder programs. In the instances that one person impacts the other's sobriety and or increases harm, what are your thoughts of the ethicality of this type of treatment model? So I think maybe what she's saying is that somebody may be in sobriety, but the person that they may be helping might be sort of behaving that might kind of threaten their own sobriety,
Oh, yeah.
or that person's sobriety. I hope I got that right.
Yeah, I'm going to try to address some of it. Is that I
Yeah.
think I don't think you need to be a therapist, by the way, to provide people some comfort, support, healing, all that kind of stuff. This is me talking as a therapist as well too. I don't think that needs to happen. So I think anybody can sort of be the person. I always like find your person. That's what's important. Like find your person that works for you. Um, this is one of the things that is always people are critical about harm reduction and harm reduction therapy in particular, the way that we practice it, because we practice it in community mental health, is that they say, because we work with people while they're actively intoxicated. So people will come into our groups and they're high. And people are always like, what's your problem? Why do you let people come into your groups when you're high? And one of the main reasons that people have a beef with that is that they say, oh, they may trigger other people. And I say, well, what a better place to be triggered than in a group so we can have a conversation about it.
Mm.
And we have to also, because we want people to be talking and not doing, right? Because we tell people it's a talking group, not a doing group. So somebody can be in the group and say, I feel triggered right now by the person sitting next to me. And now we can sort of have a process with it. So now we can drop down into the therapy. People who are providers, that are people either have had past experiences with substances or have had or maybe have current relationships with substances. Again, I go back to that countertransference thing. I go back to the need for high levels of supervision. At Harm Reduction Therapy Center, our staff get at least 3 to 4 hours of supervision every week because we work with people experiencing homelessness, people who have mental health issues, people who have substance use issues. That's 90 to 99% of our population that we work with. So we find it super important that we're always giving supervision to folks so that they can come in. That person that's a provider can come in and talk to me because we also do psychodynamic, supervision as well too. There's other ways too, but they can come to me and say, "Oh my goodness, I've been working with this client. I feel really triggered." How hard is that for somebody? So we need to rip the Band-Aid off of our stigma, our attitudes about drug use, not only with our clients, with our colleagues, with our supervisors, with our supervisees, all the rest of that as well too. Because it's no one that I know doesn't have any experience with substances, and I'm not saying using them, just they're in their lives. How many of us here have been affected by substance use? Just about everybody's hand needs to go up because we all have, if it's not just news reports. So I go back to the countertransference and supervision, and keeping ourselves also trained up as well too, and working on ourselves too. I think it's important that if you dare to share your thoughts about loving a client, which means you can also hate them, that you need to be on your P's and Q's about yourself as well too. Be thinking about and working on yourself. And sometimes that comes through supervision as well too.
Thank you, Maurice. I think we have room for maybe one or two more questions from us. And if folks have other questions, please, you can add them in the chat and we'll make sure that we ask Maurice. I wanted to ask you this question, and then if we have time, hopefully we have time, because I would like for us to close with this one. I think you alluded to some of the challenges, but I wanted to hear from you, what are some of the challenges that you have encountered when engaging in your practice through this harm reduction lens? And they can be structural, systemic.
There's a lot of structural, systemic things now. If folks are not super familiar, harm reduction is sort of under attack right now. And that's on multiple levels. From my perspective, where I work, that's on a city level. And then we have a state level, which we have legislation that has been making it more difficult to practice or be funded as harm reduction programs. Even on a government level as well too, even though Joe Biden formally said, we want to be utilizing harm reduction as the strategy. There's still been, that doesn't reflect itself in funding. So that's sort of one aspect of it. And then you have, there's a danger that's happening right now since Biden said harm reduction on TV, and then he immediately said crack pipe, which I was like, what are you doing, man? Nobody wants to hear that. It's become a political football, and so that means that the narrative gets changed, and I'm worried about who actually picks up the narrative and who's in charge of it, who has the biggest voice, who has the loudest voice. On a more micro level, that's sort of the macro. On a micro level, I think often the criticism of harm reduction is, and I like to bring criticism into the room, by the way, I think it's important, is that harm reduction enables people to use drugs. And my smart ass remark to that response to that is, we enable people to stay alive, because that's our goal. Keep people healthy as possible, safe as possible, and alive. That's our goal. And the other criticism is that that we allow people who use drugs, which to me is a bizarre criticism. But I understand why somebody would have it, because somehow, I always tell people, somehow or another, am powerful enough to tell somebody to stop, and they're going to stop. But since I'm not doing that, and I'm working with people where they're at and wherever their goals is at, people think that we're all, like crazy drug users who want to use with our clients or something like that. And that's not how it works. We're trained therapists. We work with people from that therapeutic lens, and we practice our boundaries just like everyone, and we actually need to have really reinforced boundaries, really strong boundaries, and keep negotiating and talking about those boundaries as well too. So I think those are some of the main things. I'll share with you real quick a quick story. I was doing a training in Northern California, and after the training, two people walked up to me and said, do you really let your clients use drugs? I can't believe it. Like, you let your clients use drugs. And, this used to happen. You're probably familiar with this, Tanagra, but, 15 years ago, people used to be more hostile toward you in these trainings, like harm reduction sucks. Yeah. And as I started talking to them, I was like, well, what do y'all do for a living? And both of them were psychiatrists. And I said, you're asking me about letting my clients use drugs, and you literally put your clients on drugs. And you're asking me about this, right? To me, what people were saying is that there's good drugs and there's bad drugs, right? Mm-hmm. And I always say drug is a drug is a drug. every drug has a potential harm. Every drug has potential benefits, and I think that's what can make it challenging. Is that because I did it earlier where I wanted to make sure that we're talking about coffee in this conversation as well too. Um, it's important because I think that's one of the challenges. I think people assume that we're minimizing drug use, and that's absolutely not what it is. Most of our folks who work at the Harm Reduction Therapy Center we have some expertise in drugs. I call myself a drug nerd. Like I love learning, talking about, understanding how drugs work, so that I can have a really clear understanding. But I think that could be some of the challenges, and somehow or another, one of the bigger sort of micro challenge that people are looking at now is that harm reduction has been blamed for overdoses, which is more bizarre to me because if you use naloxone, you support medically assisted treatment. Those are harm reduction interventions, and we would have double, if not triple, the amount of overdoses that we have in this country without naloxone. So we're in a weird time with it right now.
Yeah.
So there are a couple, and just for the sake of time, you might not be able to answer both of them, although one of them refers actually a point you were making from Liam. Are we over-diagnosing and over-medicating our children and youth? Are we creating a pathway to adult dependency on drugs? So that was one question. The other one was that Julie asking thoughts about corporate-owned, profit-driven methadone clinics.
The first question is just yes. The diagnosis of ADHD and spectrum autism has been overdiagnosed in the last like 15 to 20 years. So we're having way too many young people on medication whenever young people are supposed to act the way they're supposed to. By the way, you're supposed to be obnoxious when you're 5. You're supposed to be obnoxious when you're 7. And somehow or another, depends on where we're at and who's paying attention. Start diagnosing young people with ADHD. I've also seen young people diagnosed with things like schizophrenia, and we shouldn't be even looking at that until around maybe 12. I've seen this happen with like 10-year-olds. I'm like, what's happening? Like, I think we are. I think a lot of ways that we think about psychology is becoming like mainstream, and we can Google everything. Like everybody's, one of my friends said she was dating someone, and she Googled something and said he has a bipolar disorder. And I'm like, no, he doesn't. That's okay, but that's because we can Google everything. So I think ADHD. The second part was around, you said that.
Thoughts about corporate-owned, profit-driven methadone clinics.
I'm always
Your
worried
thoughts?
I'm always worried about that. Anytime corporations start getting into it, like we start getting calls nowadays, they're like, we want to invest in your organization. There's a couple of big investment groups that are going around buying up residential treatment programs and other substance use programs, and they're trying to monetize them, make them profitable. I'm worried about that because whenever, this is capitalism. And capitalism means that it's about numbers and not about health. If, at least the United States' version of capitalism, that's what it's about. So if we're driven around numbers and not health, that means that more people are going to run into more health risks. And we need a volume, and we need to actually start selling this stuff to people, right? Because that's what you need in a profit-driven place, is that you have to advertise them. And typically what we want to do is people to have a knowledge of it and come to these things, or have them refer to something. But profit driven is a problem.
Yeah. Well, Maurice, before I wanted to ask you this question as we wrap up, because I think I would like for us to close with this. If you are willing, would you be willing to share with us what are some of the gifts that practicing harm reduction therapy has given you? Well, I would love to hear.
Yes.
I appreciate the fact, thanks for that question, because I really appreciate the fact that we can truly treat people with dignity and respect. Really, like truly, like really practice the unconditional positive regard. One of the reasons I fell in love with harm reduction was that Pat and Jeannie made it okay to love our clients. They were like, "Oh, well, it's okay. You know, if you do that, just make sure you go to supervision and talk about it, right? Or if you hate them as well too. It allows me to be more authentic as well too, and it can you can be creative. You can be super creative with harm reduction, meaning that you don't have to just stand within the standards of traditional models. And that's how harm reduction therapy was created. It was saying the traditional models of treatment don't work for everyone. Let's open the doors for everyone. So our deal is to try to make stuff as low threshold as possible, make it accessible. I think it really honors people again to it once you actually sort of you can ground yourself in some principles, you can ground yourself in really trusting people, all the rest of that stuff. It makes the work easier. It makes the work easier for you. You know, there's this notion that I've heard over and over in this social service work when people say, "You never work hard on your client," and I'm like, that's kind of bullshit, you know. And I say that's kind of bullshit because I think sometimes we do need to work harder than our clients. And if you're always working harder than your clients, that's a problem. But if we can, you know, we need to work a little harder for our clients sometimes to get them to the next step or whatever their next thing is. Cool. But mostly I need to be, I don't need to be the big me, you know, and little you. Can we find some balance in our relationship, which takes pressure, if you will, off of me, which takes pressure off of the other person as well, too. And if we believe, like somebody said in the chat earlier, that trauma is like one of the main reasons that people use drugs, which is true. Quick statistics: 90% of people who run into problems with drugs have trauma in their background. If we can actually lift people up out of that little you, big me, you know, make them more powerful in their decision making in their treatment, that's actually a formula for treating trauma, is empowering people.
Mm-hmm.
How cool is that? You know, that our job is to work with people who are disempowered to help them feel more empowered.
Thank you, Maurice. Yes, Joe, you wanted to say
Now, I was going to
something?
say, I think on that note, because we just have another,
Yes.
that's a great way to end. Maurice, thank you so much. Tanagra has put in the chat box a series of trainings that Maurice and his organization are doing, I guess this summer. Maurice, is that?
Yeah.
Yes.
Yeah, tomorrow's the next one. We'll have the next one
Oh,
tomorrow. I think it's
great.
7
So
years.
check them out. Maurice is amazing. Maurice's colleagues are amazing. If you're interested in deepening your practice, they are the experts that can guide you in this. So I highly encourage folks that are in this room that are interested in this to check them out and register for those sessions. And Maurice, I just want to thank you for your generosity and your
Thank you.
wisdom, for
Thank
being
you.
for sharing it with us, and for just, you know, giving us space to be in community with you this morning. I know I learned so much. And I have a lot that I take that I'm going to be thinking about. So thank you, thank you, thank you.
Thank you. Thanks for
Yes,
having me.
thank you. Thank you.